proud secretary of Kottayam IHMA, most respected IHMA president of Kottayam chapter, and respected professional colleagues. Let us start the session. So before starting, let us have a silent prayer to the Almighty. You know that this COVID season had made us really helpless. We have known our limitations. So we are all treating human beings. Okay, so we have many limitations. So let us have a silent in 2 seconds prayer before beginning the session. So topic is dengue fever, differentials and homeopathic management. Beginning the session, I would have gratitude to my friend Dr. Simpson, who is in Dubai. Okay, so he has allowed us to use his this Zoom for as a platform. And also, I thank the Kottayam IHMA team, especially Dr. Surgeon, for taking up this initiative, and all the IHMA friends who have supported me to come to this level, and also my dear teachers and seniors. So let us begin the session. Dengue fever, the differential diagnosis and homeopathic management. The release of modern medicine has onset. Humanity has but 3 great enemies: fever, famine, and war. Of these, by far the most terrible is fever. Okay. So might be some years back, you might have had war as the great threat to the humanity. But now, okay, so see fever as a simple thing. One dose of paracetamol or acetaminophen will do the things away. But now we are really helpless. Okay. Anyway, let us move on with our topic. Our topic is dengue fever. Recently in Kerala, so we see bouts of rain, and then we have very sunny days. So this is a very favorable environment for the breeding mosquitoes. Okay, so whenever we go outside home, we go to the the garden or to the or to the farm. So one thing, all the Keralites or the people of Kottayam might have experienced is that a swarm of mosquitoes will come and they start breeding, or they start biting. Okay, so it's very favorable environment for this dengue to become, to take epidemic proportion. So really in Kottayam, this Kanjirapalli area, and nearby this Kuruvalangat, Kadipati, Urur, and many areas, having a spike in hike in this dengue cases. So that is why we have taken up this topic, and homeopathy being the first option. If it is considered for this dengue fever, it can prevent many fatalities. It's one of the excellent mode in managing the viral infections. So let us see all aspects of this dengue fever, how to manage it homeopathically, how to properly diagnose the case from the day from the initial time itself, everything we will be seeing or we will be discussing in this class. If you have any doubts here, you have every freedom to ask. You can unmute your phone and you can ask that, or you can type it. So like that. So let's move forward. So I shall begin with a case. This was not treated recently. It was treated in 2015. And at that time, this dengue fever was not prevalent. In 2013, 2014, dengue was very much prevalent, and we should have a high clinical suspicion for a case. But it was 2015, it was not that common. Okay, so let us move to that case. So this is a male patient, age 31. Okay, he came on June 3rd. So that was the beginning of the rainy season. So he had that fever since one day. That is the first day. And he tells that he had, since many days back, he was having fever. So like that, he was telling that, but that was not significant. So it's a habit of the patients who come here. They tell that even the coryza, they call this, they call it as fever. Okay, Jenny. So like there's some local names they call. Anyway, so I just noted side. Also, he was very restless. He was very weak. So he had a headache, body pain. And further investigations, case taking, appetite was diminished. There's nothing particular was there. Bowels normal, sweat nothing particular, sleep nothing particular. So considering it to be a case of viral fever, I had prescribed Naxomica individual perfoliatum 200, 3 pills 2 hours. In viral fever cases, from my experience, I have found, what I have found is that Eupatorium is the #1 medicine which covers all the symptoms. And depending on the etiology, suppose if there is a change of climate from warm to cold, so mostly Rustox I consider. And if the onset, that means the day of onset of fever. Okay, so so what was the etiology? So for homeopathic prescriptions, etiology is very much important. All of us might be knowing that. Okay, and if it was a sunny day, the change from cold to warm, from cold to warm, bryonia usually I prescribe. And on the other symptomatology, Naxomica, Gelsemium, or Aconite, so whatever comes that also I used to give. And in the earlier days of my practice, I used to give only just that indicated simile. But to my utter disappointment, see, there was just a short relief, and again it goes to the next stage. So we have to work out, we have to give the next medicine. So like that, it was a real puzzle for me. So then only I came across this Eupatorium. So for the fever, I blindly give Eupatorium along with the indicated medicine, and believe me, for almost 95% of viral fever cases, the patient never complained, even at night. So I adopted this methodology, and now I find it very beneficial. So that was my logic, and this was the prescription that was given on 3/6/2000. The first, I told them to report in the second day. There was severe weakness, breathing difficulty. There was reported by standards. So something. If the indicated medicine doesn't act, what I considered was that there is some deeper pathology lingering. So I had given SL6 doses. bacteria tincture along with blood investigations. Okay, so the third day the patient came. I told the bystanders to bring the patient on the next day. So the third day he came and the fever was there. And so he was shivering. Shivering was prominent. Extreme prostration. So he was coming to the OP. And so he was lying on the waiter's bench. So after entering the consulting, he was lying on the desk. Okay. And there was slight breathing difficulty was there. Dryness of mouth is very characteristic. The thirst was increased. The tongue was coated. Okay. So I have this pulse oximeter here. For the fever cases, I usually do the oximeter. That means you can easily see the the respiratory oxygen saturation and all the heart rate. So if we use the palpation method, we might not get it accurately. Also, since there was a breathing difficulty, the oxygen saturation is also to be noted to find out how severe that is. You can see the pulse rate was 84. The temperature was 101 Fahrenheit, and his BB was 110/70. So, do you find anything wrong here? The temperature is 101, and the pulse rate is 84. Okay. So we have studied that for every 1 degree rise in temperature, the pulse rate increases by 10. Okay, so for 101, it should be above 100. So you can get in children and all, you get 130, 140, like that it goes. So this is called as relative bradycardia. That means, usually that is an exceptional case. Usual case, there has to be tachycardia, but here, comparing to the rise in temperature, the pulse rate has come down. Okay, so there is one clinical clue that the patient is suffering from this dengue fever. This relative bradycardia is a clinical sign of this dengue fever. Okay, but we have to exclude pneumonia. So, and also this extreme prostration weakness and other symptoms. Leptospirosis is to be excluded, and typhoid is to be excluded. So like that, and this onset pneumonia is usually viral onset. So I had prescribed certain. So initially I had worked out the case using these 9 rubrics. Oversensitive to light, oversensitive to noise. So he was just closing his eyes. And respiration fever during cough, lying amelioration abdomen on, chest pain, lying amelioration abdomen on, back pain, lying amelioration abdomen on, generalitis lying amelioration during burden abdomen on, pain lying amelioration abdomen on, generalitis weakness due to. So all these rules are considered for the patient. And he was given blood routine investigations plus ARP plus NS1 age and card test for dengue and also the vital test. So he was working as an ammonia fabricator and he was going to different places. He was eating from outside, so like that. So that's why this vital test was also done. And the relevance of CRP is that even in our current scenario, this CRP is one indicator where we can assess the severity of the illness. Okay, that means CRP will be raised whenever there is massive cell injury. So that happens in viral pneumonia, and it's not that much elevated. So what I was coming to tell was that this COVID and coronaviral infections, when there is massive lung injury, this CRP will be highly raised, and CRP can be directly associated with the CT scan chest findings. So that is a, evidence-based correlation. So it's just, telling that in between. So in this case, on the 5th, these investigations were done, and his blood routine revealed 14.8 gram HB. Total count 2,600. So the count reduced. Normally is 5,000 to 10,000. So the total count was 2,600. Polymorphs 68%, lymphocytes 30%, ESR 53, platelet count 2,000. Sorry, 2,10,000, and dengue NS1 AG is positive. IgM antibody negative, IgG antibody negative. Okay. So in this we have it is a confirmed case of dengue. And this one, even the initial blood routine will give clue that the patient is suffering, may be suffering from this dengue. That means neutropenia or this lymphocytopenia. Total count will be reduced in dengue fever, as well as all of us know that in typhoid also the total count will be reduced. That has to be differentiated. So this in this the CRP was only 9, only very slightly elevated. But in viral pneumonia it will be like 30, 40, or 50, 60, like that it will go. And this Vidal came out negative. Okay. So this is how we interpret the. I'll just explain about the test also. In dengue test, we have 3 tests: NS1 AG, dengue IgM antibody, and IgG antibody. This picture will give us a good understanding regarding how to interpret that test. So this NS1 is a non-structural. It's an antigen. It is found in the surface of the virus, and the presence of that antigen is detected by the CAR test. So we know that viremia precedes fever, and after the development of the antibody, this antigens reduce. So NS1 AG will be positive only in the initial 1 to 5 days. That is why it is called as the day 1 test. So it has been in practice only since maybe some 8 to 9 years only, and now it is more used widely, and we can diagnose the dengue case from day 1 onwards. So the classical or the earlier time, we used to rely on the IgM ELISA test. So that will be positive only in the 2nd week. From the 6th day only, IgM will be positive. And the relevance of the IgG is that IgG become positive only after maybe some 2 weeks or 1 month only. IgG will be positive in case of this primary dengue. So in dengue we have the secondary dengue infection is dangerous. So to assess whether the patient is suffering from the primary dengue or the secondary dengue, this NS1-AG CAR test will reveal. In secondary dengue infection, we can see that the IgG will also be elevated. Okay, so if the IgG is elevated and NS1-AG is positive, so it is a secondary dengue case. So the secondary dengue case, we have to deal it very carefully, so that we will see when we move forward with our class. Hope things are understood for you. Any doubts you can ask. So considering the confirmed dengue, I am using this complete repertory, and this is the case was done in 2015. So these rubrics were taken: oversensitiveness to light, oversensitiveness to noise, head pain with fever, rectum diarrhea with fever. Okay, then fever, heat, dengue fever. 24 medicines are listed in the complete repertory. And fever, heat, dengue fever, first stage, 5 medicines are listed. And This many medicines I haven't seen in any other repertories. I think in Boric only 12 remedies are listed. And general weakness fever during. So the Briannia topped the list. So the prescription was changed to Briannia 201 dose. That was given in the divided way, and PL liquid was given. So, I mean, in 10 ml liquid, 10 to 15 drops of this SL will be dropped, and the patient will be asked to take 5 drops every half hourly or 1 hour. And BT 5 grain 1 tab 4 times a day, and SOS SL2 dose was given to take as the divided doses. Okay. And this is the report on 8/6/2015. This blood investigations was done. Total count was 2450. ESR 59 platelet count. So we can see that in this case the platelet count never diminished. So when we think of a case of dengue, the first thing that comes to our mind is the platelet count. Okay. So this counting of the platelet count can never be considered as a diagnostic criteria as far as dengue is concerned. Even in viral fevers, this platelet count can diminish. There are many viral illnesses where the platelet count is decreasing. Okay, so seeing the lab report that platelet count hasn't come down, we cannot say that this is not a case of dengue. So it has got definite criteria which, if we follow, we can correctly diagnose the dengue case from day 1 onwards. And on the 15th, his investigations show total count was 3,900. Okay, so it is just slowly increasing. And on 26/2015, okay, this was on 15/6, 3,900, and on 26 it came to 5,100. But his platelet count remains unchanged. Again, he had some head pain. So that was the only remaining symptom on June 15th. So for that, I had prescribed, I think, for acid phosphorus prescribed for the patient, and he was completely symptom free. So we could confidently manage this dengue case with homeopathic medicines. We support lab test to make sure that the patient is not in a dangerous situation. So in many situations, we have to refer the patient. Suppose if this platelet count is coming down, so beyond that means if it drops down below 1 lakh, we should be extremely cautious. Below 50,000, okay. So it is highly risky for us to manage that case in an OP case. Suppose you have IP facility and observation facility and other ICU facilities, you can take up the case. Okay, if that supportive management is available, then we can confidently give homeopathic medicines. Otherwise, it is better to refer the case to an hospital. Now, understanding dengue hemorrhagic fever, and dengue shock syndrome. So we know that it is caused by the dengue virus. There are 4 different strains of dengue virus. So it is denoted as DNV1 to 4. And these all serotypes can cause severe fatal disease. And there are genetic variations within the serotypes. Some variants within each serotype appear to be more virulent or have greater epidemic potential. 1 second.
Hello, doctors. There is a little bit disturbance in Dr. Felix James' audio. Pardon the internet connection in Kerala. Maybe it's raining or something there. Hope you all can hear now. He's turn off the audio for the time being. He'll be back soon.
Sorry for the interruption.
No problem. Felix, sometimes that audio is not that much clear. Maybe because of the internet connection or some other issues there.
Okay, problem with the audio. Is it clear now?
Yeah, now it's clear. Now it's sometimes it breaks. I think it's because of that internet connection in our places actually.
Okay.
Yeah, now it's clear,
Okay.
Felix. You can continue.
It's clear now? Okay.
Yeah, you can continue. No problem.
So there are 4 types of dengue viruses. Dengue viruses 1, DNV 1, 2, 4. And all these serotypes can cause severe and fatal disease. So this is one of the reasons why the secondary dengue can be more fatal, because the antibodies of the formerly infected dengue virus, they are present in the body. Okay, so the body seems to have a false sense of security that initially there won't be active defense against the virus. So the body sense that it is going to a danger position only in the later phase. Okay, so let us see how this dengue virus infects the human body. Okay, all of us know that it is caused by mosquito, Aedes aegypti. Okay, so how to identify that? All of us know. Is it a small mosquito or some big mosquito like the Anopheles? Okay, so in Kottayam we have plenty of these mosquitoes. I've caught few with my hand. I've seen that white strips. They are called as the tiger mosquito. So they are comparatively a small mosquito. Even we don't sense when they come and sit and bite and go. Okay. So can we share videos also here, Dr. Simpson? Will it be possible?
You can connect from anything. You can share from your desktop.
Okay.
Felix.
Okay. Let me see.
Just to minus this slide.
Okay.
Because you are sharing your screen now. You can play video also.
Okay.
So you want to demonstrate how a mosquito bites?
Is it clear?
Yeah. Now we can see the video also. Yes.
Is the sound clear?
The audio is not clear. The audio is not clear, but video is almost clear.
Mosquito can live for about 2 to 3 days. Only the female Aedes mosquito will bite to extract blood in order to support the production of eggs. If the blood meal is insufficient, she will keep biting until she has enough blood. On an average, she produces 3 to 4 batches of eggs in her lifetime and about 70 to 80 eggs per batch. Male mosquitoes feed on plant juices and do not bite as they do not need to suck blood. In its search for blood, the female Aedes is attracted to carbon dioxide, body odor, and body heat. With less than 5% of the skin being blood vessels, the mosquito searches for them by probing the skin with her proboscis. Once a blood vessel is found, the female Aedes mosquito freezes and starts drawing blood from it. She will release salivary secretions to prevent the blood from clotting, allowing the mosquito to feed efficiently. It is this mosquito saliva that will cause the itchy red lumps in the victim. The amount of blood a female mosquito can take at one time can be up to 4 times its own weight. And to fit all the blood in her stomach, she will discharge the liquid content of the blood from her abdomen. Having taken a full blood meal, the Aedes mosquito will find a place to rest before looking for a suitable habitat to lay her
Felix,
eggs.
your
When
video
that
is not
done,
shared. Only they can see the photo only.
when a person has a dengue virus in his bloodstream,
Felix,
the female Aedes will suck in the virus with the blood.
Is the video not shared?
yeah, I was
Hello?
able to see that, but many are telling they cannot see that. They didn't see the video.
Okay. Now is it possible?
You can try again,
No.
Felix.
Okay, one second.
Now it is almost clear.
Because of some disruptions in the internet connection, that is a problem. Like another time, people are most of people all over the world are on internet. That's the reason.
Is it clear now?
Dr. Weiss, how is it now? Yeah, they saw the site. Yeah, so if they have seen it, no problem.
And
Okay,
finally, to adults. An adult mosquito can live for about 2 to 3 weeks. Only the female Aedes mosquito will bite
The
to
audio is not clear
extract
that
blood
much.
in order to support. If the blood meal
Okay. Maybe I will just explain it.
Yeah, that's better, Felix.
Okay. I hope all of you can see the screen now.
Now we can see the screen
Yeah,
clearly.
instead of audio, Felix, you
Okay.
can narrate that. That is better.
The thing is that the mosquito insert the proboscis and then it injects saliva. Okay, it injects saliva as an anticoagulant. And only it can suck. So when it injects the saliva, the virus enters the body. So that is how the virus is entering the body. So that is what is shown here. And when it sucks blood, the infected patient gives the virus to the mosquito. And this Aedes aegypti mosquito, okay, it travels only around 100 meters. So there is a chance for us to get dengue only if a person is infected with dengue virus in the circumference of almost 100 meters. Okay, so that is one thing which we want to know when we identify the contact. So from where the patient got the dengue. And usually after a visit to the hospital during this dengue epidemic season, so they might get an infection from the hospital. But most of the hospitals, they are, this also you have to advise the patient. So this is for a diagnostic case of dengue. Should advise them that they should use the mosquito net. Okay, so to prevent the people from at his home to get the infection. So that all that measures also we have to give advice. Okay, and one more video is there. This is how the dengue virus infect our cells. So this is general video. Also, we can understand about the mechanism of virus replication. Okay, so the virus is entering the body through the proboscis of the mosquito. So it is a very good animation. Okay, this green thing is the virus. Okay, these are our neutrophils. Okay, they come and attach to the neutrophils, just penetrate, enter inside the cell, And we know that after entering the cell, the genetic material, so that is replicated. So one virus become thousands. Okay. So within hours, this replication stops, and then you can see thousands of virus coming out from that cell. The cell is damaged. Thousands of virus comes out of the cell, infecting other thousands. That is how the virus replicates. Okay. So in this scenario, the body's defense mechanism is very vital. The production of the interferons. These interferons makes the cells impermeable for the virus to enter. That is the first line of, one part of viral defense mechanism. And from my inquiries, what I have understood is that one of the most important defense mechanism of body to combat viral infections is the fever. Okay, so there are studies showing that for every 1 degree rise in temperature, the replication of virus comes to stand still. So depending on the virulence of the virus, the body sends messages to the hypothalamus. The hypothalamus is the fever center of the body. So the hypothalamus decides to set the temperature level to 99 or 100 or 102 or 105. If it is very virulent, there will be sudden rise of temperature. That's why we feel that rigors and chills and shivering and all is a muscle activity to raise the core temperature. So when the temperature rises, the replication of virus just comes to a stand still, and the final culmination of the body's response to this virus, that means these antigens, is the production of the antibodies. Once the antibodies are produced, these antibodies come and lock up the virus. Okay, you know that antigen antibody mechanism, and all the viruses are incapacitated. So we know that by phagocytosis and by other mechanisms, this virus cannot be damaged completely because they enter the immune cells and they start multiplying there. Okay. So the efficiency of one's body to develop this antibody, that can be considered as the efficiency of his immune level. The faster the patient or the infected individual develops the antibody, the virus clears off in the very fast. So these antibodies, they are very highly specific. For example, in chickenpox, the virus doesn't change its shape. So we know that once a patient gets infected with this chickenpox, okay, so it is quite natural that he develop maybe lifetime immunity. Again, reinfecting the same virus, the patient doesn't develop chickenpox. So this is the but in this dengue case, similar types of 4 different strains of viruses are there. So there is partial immunity. So that is why secondary dengue is very much okay. So let us move with the. Now I think we have understood the mechanism of the mosquito, the viruses, etc. The incubation period 4 to 10 days after the bite from an infected mosquito. And this is the usual clinical picture that we get. The patient develops high grade fever suddenly, usually lasts for 2 to 7 days. So in dengue fever, it is a biphasic fever, it is told. 2 to 7 days, and is often accompanied by facial flushing, skin erythema, generalized body ache, myalgia, arthralgia, and headache. Weakness and debility to the extreme level. So that is one of the characteristics feature which I have seen in patients affected with this dengue fever. Even the way they come to the clinic, so we can have a, suspicion that it is something serious. Okay, so that much extreme debility. May have sore throat, injected pharynx, conjunctival injection, anorexia, nausea, vomiting are common. The mild hemorrhagic manifestations like petechia and mucous membrane bleeding from nose, gums, they may also be seen. And mostly that is a hemorrhagic type. And massive vaginal bleeding in one of childbearing age. And gastrointestinal bleeding may occur during this phase, but it's not common. The liver is often enlarged. So when we palpate, we can see this hepatomegaly and tender after a few days of fever. Notable signs, petechia and relative bradycardia. Petechia, it was not possible for me to identify that. That means you tightly, tight the BP cuff, and after some 1 minute and all, you see, no, it was not possible for me to identify such things. What is told in the textbook? Maybe some of you might be possible for you to identify that. And relative bradycardia, that is one of the important clinical sign which I have observed. You may ratify that in your clinical settings also. Okay, tourniquet test for petechia. And okay, secondary infection tend to produce dengue hemorrhagic fever. So this is one simple chart which will give us an idea regarding the severity of the dengue. So when we approach a case of dengue fever, it is highly essential for us to exactly, that means to get from the patient from which day the fever started. Okay, so the initial 3 days there will be a high fever will be there, and the most fatal phase of dengue is in between 4 to 7 days. So there will be initial hike in fever. The fever just comes down, and then suddenly the patient can develop shock and dengue hemorrhagic shock or dengue shock syndrome. Okay, so that's what usually we see. Okay, the patient develop fever, go to hospital, they take medicine, they tell that it's okay, go home. Okay, suddenly the patient collapses and we see he's normal. Okay, so we have patients coming to us with camouflage symptoms. They'll be taking this antibiotics like acetaminophen or brufen or mefenamic acid. So like such medicines they will be taking. So outside they won't be having fever. So such cases we should be extremely cautious. Okay, so if there is an epidemic, you should make sure when the fever developed, and we should take care to give investigations. Then in laboratory, the hematocrit, okay, so that will be reduced, and viremia in the initial phase, IgM, okay, the later phase that we have explained. Laboratory criteria: leukopenia, thrombocytopenia, antigen detection 1 to 10. Told in the textbook 1 to 10, but usually after 6th day, we don't get NS1 Ig positive. Usually, sometimes it might be weakly positive. Okay, and after giving homeopathic medicines, NS1 Ig became negative. Okay, so can we take it as a credit that homeopathic medicines made NS1AG negative. Okay, I don't think after understanding the thing we'll be thinking in that manner. So that is why we should know the clinical relevance of the investigations. Okay, and we should be possible for us to update our clinical knowledge depending on the time of depending on our time. Okay, and also the PCR polymerase chain reaction. So that might be in the earlier days. This might be the diagnostic feature of dengue, but now this such a costly test is not needed. So NS1 is the non-structural protein. High concentrations of these antigens in the forms of immune complexes could be detected in patients with both primary and secondary dengue infections up to 9 days after the onset of illness. As we have explained. So these are the rubrics. Fever, heat, dengue fever, aconite, eupatorium, gelsemium, rustox are given as the most prominent medicines. Also bryonia. And the first stage, aconite, arsal, bryonia, epicac, and rustox. And hemorrhagic phase, arsal, china, Ferramet, Hamamelis, Cicalicor, and sulfuric acid. This is one of the chart which we have developed on behalf of the IHRC. Diagnosis and treatment of dengue fever, guidelines for homeopathy practitioners. Day 1 to 3. Okay, so it is class. Like this: day 1 to 3 and day 4 to 7. Two classifications are given. Okay, so day 1 to 3. Blood investigations is suspected case dengue, NS1AG and IgG. NS1AG positive, IgG negative. So primary dengue. Advice isolation. Query regarding possible contact. Distribute preventive in the area. NS1AG positive, IgG positive. Secondary dengue. Extreme caution needed as cases may develop DHF or DSS. Platelet may not be low in initial days. Leukopenia may be present. And the cases have been worked out. Medicines. Gelsemium, bryonia, eupatorium, rustox, china, aconitum, arsenicum, naxonicum may be selected based on the totality. And day 4 to 7. Okay, the symptoms: mouth hemorrhage, gums, fever during abdomen pain, fever during blood hemorrhage, fever during skin ecchymosis, fever during. So like that rubric was considered, and fever, heat, dengue, hemorrhagic. So like that. So the medicines: china, gelsemium, arsenicum. Arsenicum is one medicine which is indicated in all the 3 stages. Okay, fever, heat, dengue fever, and also in the first stage and also in the 3rd stage. Arsal is is given, is listed in the repertory. China, gelsemium, arsenicum, ferramet, baptisia, rustox may be selected based on the totality. A sample repertory chart is given below. Okay, so that is some idea regarding the dengue fever. So any doubts you can ask. And we will move on to the differentials.
So your presentation is over, Felix. Then we will move to question and answer session. Hello, Felix. Hello.
Any doubts?
Felix, your presentation is done, no?
Hello.
Can you hear me, Felix? Hello. Hello, Felix. Hello. Hello.
Okay.
Felix,
Anyway,
can you hear me?
with the class. So after the completion, you can clear off your doubts.
Hello.
So while taking the history of a fever case, our objective should be: is there a foci of infection? Does the patient show any signs and symptoms of? One second. Sorry, Dr. Simpson. I was not able to hear. Okay, please.
Now it's okay, no? Now it's clear.
Now it is okay. Now it is
Okay.
clear. Now it is clear. Okay.
So that means you finish your presentation. Now we are moving to question and answer session, or you want to continue something else?
I mean, now I have just presented the dengue. Now
Okay.
the differential diagnosis is to be talked in brief.
Okay.
Now regarding this dengue session, if any specific doubts, we'll clear that off and then we'll move on. Or
Okay. Then I will
just-
unmute all, and those who want to ask the questions, they can ask one by one, or they can raise their hands.
Okay.
Better to mute all and allow those who wants to ask the questions. Otherwise, you will hear the children crying, and then some household things are being there. No? You know, the time is like that. Maybe they're ready for the dinner and other things are happening there. So somebody, if you want to ask the questions, or they can type the questions, they can chat with the questions. That's
if
better.
anyone, okay, if any,
So if you can check the chat, they will ask to the chat. That's better.
Okay, you type your questions in the chat box. Where is the chat?
It's there. You're not able to that. Just go to the downside. You can see that that you have seen that mute video security participants, then chat. Did you see that screen sharing, Felix? Just before that.
Okay. Yeah. Okay. Now it's okay.
Okay.
Chat. 26 chats have.
Yeah.
Let
So
them
far-
unmute themselves. Okay, better to ask here. Yeah. Okay. Hi, doctors. You
Yeah.
can ask questions here. Yes.
No questions.
Okay. I think we'll continue with the class. Okay. Shall we?
Yeah, we can continue. I think people are well aware of
Yeah.
dengue, and otherwise they
Okay,
didn't
okay.
understand anything. Maybe they are
Yeah,
just
yeah.
turned on the session, and then they are doing their household
Okay.
things. We can't blame their own experiences.
Okay.
Sir, please, one question is there. Sorry, 1 second. Sir, please
Yeah.
share experience in differentiating medicines in dengue cases.
Okay.
Or we will do it at the end after discussing the DDs also.
Yeah.
That is better, I guess. Yeah.
Okay.
Continue, Felix.
Okay.
Continue.
Okay. Thank you. Okay. 1 second. Let me. Is my screen shared? Okay. 1 second.
You can share it.
Is it clear? Can you see the screen?
Yeah.
Okay.
Yes. Objective in history taking.
Yeah. Okay. So, is there a foci of infection? Does the patient show any symptoms and signs of viral disease so that urgent referral is needed? Strong clinical suspicion regarding the prevalent epidemic. So, now all of us have COVID in our mind. So, in a case, fever case coming to us, okay, we are trained to rule out COVID. But we shouldn't miss other prevalent epidemic that might be spreading in our locality. So that is why I have taken up this session. Now we see viral fever cases coming in plenty. So we might also come across dengue fever. But if it is a COVID case, it should be possible for us to identify that too at the earliest. Okay, so that is the clinical expertise that we should gain from this class. Okay, so rule out any foci of infections and also the exciting causes. This tonsillitis, pharyngitis, sinusitis, ASOM, bronchitis, bronchiolitis, myocarditis, arthritis, appendicitis, hepatitis, cholecystitis, meningitis, cystitis, or wounds. So this physical examination, we should do it as a protocol. So being homeopaths, after the detailed case history, we'll be tired, and when medicine, when we feel confident that we have found the medicine, there is a tendency for us to prescribe and wind up the case. But even from the beginning of our practice, we should make it mandatory to examine each and every case, especially these fever cases. Okay, so in a hurry, we should never skip up doing these examinations. Okay, so for that, we should have a torchlight handy, and this I think all of you might have purchased this thing. Okay, this is a very effective tool to identify whether the patient has got fever or not. So I have been using this for the last 9 years. So from my experience, what I have observed is that, okay, so usually we see the temperature in the forehead. Okay, so it is, but in most of the viral fever cases, the forehead temperature might be normal, but you take the temperature on the throat. Just ask the patient to open his mouth and take the temperature on the throat. So in the throat, you will see temperature 100, 102, like so, like that. So from my experience, so that also you can get the, the core temperature as well. Okay, and also do all the examination, this nose, throat, and all, and ear, all you have to examine. If no foci found and no clear exciting cause are known, it is a case of epidemic fever. So we should have a sound knowledge of the epidemic that is prevalent in our community. That helps us to avoid wrong diagnosis, unwanted investigations, and it's a great benefit for patients as well as doctors. So these are the viral fever, HFMD, dengue, viral hepatitis, COVID-19, leptospirosis, typhoid, malaria, meningitis, IML, everything we can come across. This viral fever, okay, it's very simple to diagnose. All of us know the mechanism, etc., etc. And our coronavirus also is listed as a respiratory virus. Signs and symptoms mostly similar to the influenza. And this influenza has got every tendency. There is one of the most feared complications, that is development of pneumonia. In influenza, usually we get bacterial pneumonia. Very rarely we get a viral pneumonia. That means the virus, they damage the cells, and this damaged cells acts as medium for the bacteria to develop. So bacteria come as the saprophytes. So that is why in the allopathic or the modern medicine, they give this antibiotics as a preventive measure to combat this bacterial pneumonia, not to fight the viral infection.
എല്ലാ ദിവസവും ഉണ്ട് 8 തൊട്ട് 9 വരെ ഉണ്ട് ISKയുടെ നമ്മുടെ ഗ്രൂപ്പിന്റെ അകത്ത് മില്ലേനിയം ഗ്രൂപ്പ് ഇല്ലേ നമ്മുടെ ഗ്രൂപ്പിന്റെ അകത്ത് വരാം നോക്കി
bronchopneumonia in children. Okay, so this is we have to look into the respiratory rate in children. If it is above 60, up to 2 months, and up to 2 months to 1 year, above 50, and 1 year to 5 year, above 40, and in older children, above 30, respiratory rate is significant. That is risky. Pneumonia can, and also this estimation of the oxygen saturation and ESR will be increased, leukocytosis, blood count will be high, and chest X-ray is the confirmation. Okay. Rubrics, we have many rubrics. Influenza in headache, nose coryza, cough influenza after cough influenza during, then chest inflammation, lungs pneumonia. So like that, we have lots of rubrics. HFMD, I don't think there is much description is necessary. Infects children mostly between 1 to 5 and 5 to 10 also. There is chance for them to develop this HFMD. It's caused by Coxsackie virus. So here comes the importance of examination. So the patient will be brought to us with a complaint that he or she is not taking feed properly. Child is not taking feed properly. Okay. So we examine, everything else will be perfect. But when we start examining the throat, we can see the small ulcers on the side of the uvula, or on the tongue, or on the tonsils. So that is where we get the lesion at the early phase. Then only it comes to on the face and in our hands or on the feet. So if you see that lesion, if you examine the sole or hand, we can see other reference also. Okay, so we can confirm that it is a case of HFMD. Again, you can tell the patient that this is the case, and she will be, or she will be developing lesions in the hand and also on the feet. Okay, and the prescription is very easy. Astox, I give usually 201 dose, or Merxol 201 dose. Only that is sufficient. Okay. Next, an incubation period 3 to 7 days, and if it is a case of HFMD, should advise. There is a chance, not chance, it's highly infective. It spreads through the saliva contact. Okay, so usually the child gets this HFMD after he is taken to the Anganwadi or the nursery school. Okay, though there mostly, and there are more than one strain which causes the infection. Coxsackie virus A16, enterovirus 71, enterovirus group. Okay, so more than once the patient can develop the HFMD. Maybe 3 or 4 times he can be infected with this HFMD. Okay. Then viral hepatitis. Okay, all of us know. So HIV, IgM, HIV to identify hepatitis A. Leptospirosis also is a very dangerous disease. Urine investigations and also blood in leukopenia will be there. Okay, if urine is bloody, I have to suspect this leptospirosis. From my experience, it is better to keep off hands in this leptospirosis cases, because antibiotics works very effectively and efficiently. So it's better to refer the case to a good hospital or to the medical college. Typhoid also better to keep off hands, but there is the chance for developing complications. Okay. Then IMN is has great scope with the homeopathy. After incubation period is 4 to 6 weeks. Fatigue, malaise, myalgia, sore throat, so etc. There will be lymphadenopathy and splenomegaly, hepatomegaly, rash, periorbital edema, parietal, and jaundice, etc. will be there. So the count will be very high, and IgM for infectious mononucleosis is the confirmatory test. So my meningitis also we should be very cautious. You have to. That's why I'm telling that we should do the examination. Okay, so we shouldn't miss out this neck rigidity and suppose the type of vomiting, etc. So that all. From the examination, we can rule out that the patient doesn't have this meningitis. So some maybe 3 or 4 years back, I got a child. Okay, so he was seen by many doctors, but that was a case of meningitis, and he was referred to the neurologist, and he was admitted and treated, and he was relieved. Okay. So clinically, if total count is increased, increased in leptospirosis. Sorry, earlier I told that it will be decreased. Increased in leptospirosis and decreased in dengue and typhoid. And polymorphs increased in acute infections. Lymphocytes increased in chronic infections. ESR increased in typhoid, leptospirosis, malaria, pneumonia. Platelet count will be decreased in dengue, malaria, and viral fever. And this polymorphs and total count will be decreased in dengue and typhoid. And in urine, albumin increased, and pus cells and RBC will be seen in leptospirosis. And COVID and CRP, this is the paper, one paper which I had come across recently. The early stage of COVID-19, CRP levels were positive, and it is just correlating with the lung lesions and could reflect the disease. UTI, that is another important thing which we should take care while treating this fever, recurrent fever, chills, etc. And now in Kottayam, since the rain has started, there is no this rare chance for getting this urinary tract infections, but some 1 or 2 weeks back, when the climate was very hot, in many cases we could diagnose urinary tract infections. Okay. HB percentage in dengue, HB concentration will be increased. SGPT, ALT increased in hepatitis and leptospirosis. CPK increased in leptospirosis, myocarditis, creatinine is increased in leptospirosis. There's some special test. NS1 Ig for dengue, IgM ELISA for dengue, IgG ELISA for dengue, IgM ELISA for leptospirosis, monospore test for IMN, or IgM antibody test for IMN, Vidal for typhoid. Okay. So now we'll wind up the class, I think. Okay, thanks for your kind cooperation. If any doubts, you can ask.
I think you can better chat with the questions, then I unmute them, because now it's they're maybe having dinner or something at home. So it's better to they can chat. That's better. And Felix, there is one question. Can you show physical examination of meningitis? Anything to be cautious in Klebsiella utae? Sir, I have posted doubts. Felix. Hello. One second. Felix, you can unmute your audio. Hello.
Okay. Yeah. Is it clear? Okay. Physical examination, I think all of us know that. Okay, you know that Kernick's test. Okay, to examine the neck rigidity and also the Brudensky sign. Okay, it's not that much difficult. I don't know how I can demonstrate it in the Zoom video.
Yeah.
Awkward.
Then please share the differentiating medicines in dengue cases fever.
Okay. And Klebsiella, I think in
Klebsiella
UTI and
UTI.
all, UTI and all, usually we don't do the culture. Okay. So this culture and sensitivity is done to identify the bacteria and also which antibiotics is, killing them, and which for which they are resistant. So like that. Okay. So this, even for in this antibiotic resistant UTI infections, our medicines can be used very effectively. So, Uvaursi tincture, that is one of the medicine after many disappointments with this our constitutional medicines like Lycopodium, Staphylococcus agria, Pulsatilla. So Pulsatilla was the initial favorite remedy. So later after appreciation, I found Lyco and Staphy equally effective. And also this Cantharis in the initial stages. Then arsenicapal prex, that is one of the medicines which have given frequently, and it has cleared off many cases. But there were many stubborn cases which doesn't respond to all these medicines. And one great remedy which I have found from my experience is Uva Ursi tincture. You may try that Uva Ursi tincture. I usually give 5 drops 4 times or 10 drops 2 times. So like that. Okay, so it gives good results. Good results. The puzzles from 20 to 30, so like that it comes down to 1 to 2. Okay, so very effective.
Felix, can I add one more point into that? See,
yes, of course.
Yeah, it's better to see. We can do the culture also, because sometimes it will be a Klebsiella induced one, or it can be E. coli one also. So if you do the culture and give our medicines, then see which medicine will be more suitable to fight. Whether, so for example, if you are giving Cantharis and it is giving results, we can say Cantharis is effective in E. coli induced UTI, or we are giving ORC tincture if it's a Klebsiella one. So that also it will make our medicine, the prescription, more perfect and scientific also. Even though we say our medicines are acting based on the similar principle, but we can also prove that these are also acting like some kind of antibacterial or antimicrobial effect is also there actually. So that will add our knowledge also. That's good actually. And the way how you are approaching the case is also fine. In acute cases, we have to use the lower potencies, because last week I did a presentation on a novel study of Mitivedica, how we can approach Mitivedica. I uploaded already that in my YouTube channel. You can also view that. So we have to we have to enhance our knowledge, and we have to go into the other way, how the other schools of medicine are approaching the cases. That doesn't mean we are deviating from the principles of similia, but we are extending to their territory, or we are extending to their way of approaching the cases. So if you're culturing a urine or any culture, then you are giving the medicines, and then if it is giving effects, we can say this is a combined effect. What you can say, based on the similar principle, it is affecting the, or it is acting as an antibacterial or an antimicrobial also. So that kind of approach can be also done in our settings. So that will boost the confidence of the patient. Second thing, you can speak with the other doctors also. Saying,
thank you,
I have given this medicine. This is what I learned from my experience working in a multicultural environment like Dubai and other places, where we have an immense coordination with other doctors also. That's why I shared a case like shared an experience with the senior gynecologist. She's taking our homeopathy medicines for COVID preventive, and she said me like they have seen 5 to 9 cases of COVID patients delivering healthy child, not much infection in them. So this is the way how we can learn from their experience also. So this is a positive thing we are doing. That doesn't mean we have to focus only on the culture report or anything. We can use our principle, but this will show that this is effective in the other way also. I think Felix, more people are moving towards UTA rather than
UTA. Yeah, it is okay.
Anyway, that's his practical one only. It's like
even
of course, we do some kind of radio talks in Dubai, the topic will be maybe something like infertility, but the question will be from eczema or hemorrhoids or psoriasis. So this is natural from our doctors group also. So the question is anything to be cautious in Klebsiella UTI, E. coli UTI, more common, I think. E. coli is more common, I think. In case of Klebsiella UTI, can we expect Klebsiella pneumonia as complication if not managed properly? That's the question.
Okay.
See, what I feel is like Klebsiella pneumonia and the Klebsiella UTI is different actually. That doesn't mean those who are infected with the Klebsiella UTI will go to Klebsiella pneumonia. It will not happen like that. Even though it's like a candidiasis, oral candidiasis won't go to other candidiasis. No? So it's not directly connection, but it's mainly due to what you call. We mainly see Klebsiella UTI, but the commonest presentation is E. coli UTI. I think Dr. Felix, you can take another class on UTI.
Yeah. And here another question: how did culture helps to select medicine, especially in UTI? Yeah, of course, more studies are needed, as Dr. Simpson doctor told. So we have to correlate. That means the culture report with our medications, and even the, bacteria resistant items can be managed with homeopathy. If we can prove that, then we can get that correlation. Suppose if this bacteria is infected, this type of symptom totality we get, and this medicine is indicated. So like that. So for that, further studies are needed. One medicine for 8-year-old lady with a chronic recurrent UTI. Okay, so that case is to be taken in detail. Again, you have to work out the case, and then only we can find the medicine. What medicine giving in severe UTI passes numerous? Okay, if you find that all other medicines have stopped working, try you oversee. And also another thing, okay, the intake of water. That is one thing which we should make sure that the patient is taking sufficient amount of water. Okay, so otherwise when the urine is concentrated, there is high chance for them to develop this recurrent UTI. In most of the patients with recurrent UTI, I have seen that they have a chronic tendency, or they have a habit of not drinking water. Okay, so making them drink water something, sometimes we tell that we make him drink water. So we consider it as something what this not a good thing. Might be because of that they are not drinking water. I don't know.
We can say an adjuvant therapy like hydration.
Yeah,
that's also important actually. Then one interesting question, Felix, there. That Chikungunya could coexist with dengue. How to deal it? Good question. Chikungunya with dengue.
Okay. This both this Chikungunya and this dengue almost similar viruses. So we had in Kerala in 2008 and 2009, we had a massive attack of Chikungunya all throughout. It started from the Alapi district, and the next year it spread to the southern Kerala. The next year it spread to the northern Kerala. So like that. Okay. So both are different diseases. Their presentation is entirely different. And we know that when we have treated Chikungunya with homeopathic medicine from the onset, okay, those patients very rarely developed the, sequelae or the complication. That means most of the patients who were infected with this Chikungunya, okay, so their joints were absolutely, it became functional. Mostly, mostly the aged. But we know that those patients who had taken homeopathic medicines, even after this 10 or 12 years, they are perfectly all right. And
Dr.
your question was
Dr. Felix,
differentiating between differentiating between dengue and Chikungunya. Okay, so from the symptomatology itself, we can clearly differentiate. So in the Chikungunya, it comes as the pain in the lower extremities mostly, either in the ankle or in the small joints of the feet, of the hand. So then with chill fever, so like that it develops. It's entirely different. So we can easily differentiate that. And this, for chikungunya, we don't have a reliable blood test, I think. But in dengue, we have a blood test. So it can be clearly differentiated clinically. Yes, Dr. Simpson,
Yeah.
please.
So suppose if somebody contracted chikungunya, what is the chance of they infect with dengue fever? Do there any protection of chikungunya IgM? That means it prevents dengue fever occurrence. Anything, any observation or any literature on that?
I don't know. You have to refer if any studies have been done in that manner, but from the clinical experience. So both the chikungunya. Okay, so after that epidemic in Kerala some 10 or 11 years back. So after that, we don't find chikungunya here, but dengue seems to come as a sporadic disease off and on. Okay.
Okay.
And that we have to refer if any studies are available. Let me see. We will share that. Okay.
Yeah, we can also learn from that. Like we can also do some kind of clinical observation from our patients also, like whether chikungunya IgM is able to protect from dengue virus also. Because see, if there is IgM in our body, it will be if the virus is more or less similar to the IgM which is having in our body, maybe the clinical what you call the presentation or the severity and the duration of the disease can be reduced.
Yes.
So, but I am also very early to comment on that. But we have to refer some literature, and we have to. That's a very good question actually, like chikungunya and dengue fever, because our rainy season is going to start in Kerala. So, such kind of things to be differentiated. Fine differentiation is most important for us also to know. So, don't be reluctant to do our what you call investigations also. If you doubt history of chikungunya, just do the IgM. We can see whether the patient is having IgM in them also.
But this IgM and IgG for chikungunya, I think.
Sorry, not IgG, not IgM, IgG for the long protection.
Yeah,
not IgM for immediate one.
But I think there was some restrictions for doing this IgG. I think the test was withdrawn.
Okay. Now sometimes that sensitivity also varies.
Positive. I don't know. Yeah, I don't know.
Depends on
it was
the
there
reagent and all.
Till some few years back, but I think it was withdrawn.
Okay, there is one more question, Felix. Can they coexist? That means chikungunya and dengue fever can coexist in a single person, in a single patient or in a person.
Now, from my experience, I have never seen such situation.
Okay. Then Dr. Dikshit Lakhani explained body ache more found in chikungunya, joint pain is more severe, headache and weakness found more in dengue fever. But these kind of clinical symptoms are not much helpful to differentiate, because even corona also we are facing the same problem. Like majority of them are like what you call asymptomatic carriers, or they have only mild symptoms only. So based on the simple clinical feature based or symptom based classification is not up to the mark. Am I correct or not, Felix?
Okay. Yeah, exactly. Then,
but when an epidemic comes, first diagnose the case, then rule it out, unless otherwise proved. Suppose if any patient catches cold in Dubai, we consider them as COVID patient, unless otherwise proved in an epidemic season.
Yes. Okay.
And one more thing to add, Dr. Felix, I call chickenpox as our pet virus. That is the sense, once we are contacted with the chickenpox, what happens? This chickenpox varicella zoster virus can coexist in our body, like it can be present in our dorsal root ganglia, DRG, and it can rest in trigeminal nerve or in geniculate ganglion. And the viral DNA is a circular DNA that varicella zoster is having a circular DNA that will rest in the our neuronal nucleus without disturbing the function of the our DNA. So it's like a small cat. Its curl and sleep near to us. It's like a pet That's why always called varicella zoster virus, or chickenpox virus is like a pet virus, so humanized one,
Okay.
not causing any other issues, unless and until, you know, if you irritate a cat to such an extent that then only it will start biting or crying, no. So if your immune system is so weakened, then only again it will going into varicella, what is called herpes, herpes virus, herpes simplex, or I mean we have seen herpes there. But otherwise this will coexist in our body. The circular DNA will be there, but it will not get attached to our DNA, and it will resist in the neuronal cells. So like that, since Dr. Felix told, like now we are not seeing chikungunya fever in our community. Maybe this virus is more humanized. It is not. We have developed good amount of immunity with IgG. Sorry, not IgM, IgG. Maybe that's not causing much communal spread or any kind of epidemics there. But since dengue fever is coming with different strains, that is causing more harm to the community.
Okay.
Then one more question, Dr. Felix. Likewise, any other virus or bacteria that could come with dengue, any clinical experience? See, I can just explain one point. See, secondary bacterial infection is very common if your immune system is dampened with any kind of viral infection. That is why even in COVID also, that Western medicine or modern medicine, they are giving azithromycin or other gram negative or gram positive antiviral medicine, antibacterial medicine, because secondary bacterial infections are very common. Because once the immune system is dampened with the virus, any bacteria can flare up in the body. You can even Klebsiella or Mycoplasma or Streptococcal or Staphylococcal bacteria can, because our immune system is so weakened, because it is focusing more to fight with the virus, then other bacterial infection can come up. But is there any other virus with dengue? Anything from Dr. Felix to add?
Likewise, any other virus or bacteria that could come up with dengue.
Come with dengue.
Yeah, come with dengue. See, that might be an extremely rare case. Okay, so let us know that if someone is present inside, okay, so it is just enough for us to identify him.
See, actually speaking,
okay, so,
our body consists of trillions of viruses there. There are harmless viruses coexisting in our body. So what have they are all like a humanized one. It's like a commensal. This is not causing much harm on us. So that's not causing many diseases. But there are certain viruses which will enter into our cell, causing replication of their RNA or DNA. So the other thing, they are not causing any harm, and we have, see, the continuous hand washing and other thing, even we are destroying the what is it, beneficial bacteria. Even if you know, like if you take an antibiotic, your gut bacteria is gone. So that is also causing many problems to us actually. So but this combination of dengue with other dangerous virus, as our organon says, when a powerful disease comes, the other one will not manifest there.
Yeah, see, we are asking such questions because we learn in organon what happens when two dissimilar diseases meet. When
yeah,
two
one
similar
will repeat.
diseases meet.
Yeah.
So like that, huh? But in our clinical practice, when in the practical scenario, very rarely we come across such cases.
Okay,
And
Dr.
one thing,
Felix, they asked because HCQ is given in dengue patient. See, that hydroxychloroquine is given to stop the replication of many types of viruses. That is why, not to prevent any secondary bacterial infection, they just to prevent the replication of the virus, they are giving HCQ, hydroxychloroquine. That is why they have given it in dengue, they are giving it in COVID, and also even Donald Trump, the American president, simply taking HCQ without the doctor's warning also. So that's not, it's not a wonderful or magic drug or anything like that. That they found that certain viral replications can be prevented with HCQ, and it is not causing much damage to the lungs. Other than, there is no other curative effect from that HCQ. Then the same question is repeating, specific medicine to increase the platelet count, Felix, other than Similimum.
Okay. Hello, that question was asked by Dr. Ebiman George. Okay.
Yeah, you do
Anyway,
monitor.
we all hunt for such specifics, but let me tell you, before without getting a, foolproof data, we shouldn't make any comments that this medicine will increase the platelet
Platelet count.
count. So like that. So from my experience, this arsenic emalp 3x, that is one medicine which I used to give, because patients will come to us that their relative or some dear ones are affected with this dengue, and I admitted in ICU with spread doses and have got excellent results. Okay, but I don't think it can be recorded. You have to make more studies from my experience. Okay.
Any
Thank you.
experience with the tinospora, Dr. Felix? For maybe for platelet count enhancement.
I haven't used that medicine. And another medicine which the all homeopaths favorably say is X-ray. But
Some say papaya.
Yeah, carica papaya, tender leaves extract.
Yeah,
So
tinospora. They have done the studies in Ayurveda, and they have found that it increases that platelet count. So what I want to tell you is like, no, we have to learn the mechanism how the platelet is being produced in the body, platelet production and the destruction of platelet. Then you will see how we can incorporate our medicine's efficacy. Homeopathically, we cannot say specifically that, as Dr. Felix suggested, then it's not homeopathy. If you are saying it's specific to increase only the platelet, it's not pure homeopathy. Like there are other medicines. The medicines which are acting on the spleen will definitely have an action on the platelet production also, and on liver also. So you have to learn, relearn the what you call hematology, then link with platelet production. Then Dr. Karthiani Shekhar, tinospora used in post-cardiac problems also. See, tinospora, it is having wide range of actions on the body, not only for the platelet, but there are literature in other system of medicine like Ayurveda. They did some studies on tinospora and platelet count. It is there in the literature. Okay, Dr. Felix, any other questions?
Okay.
Anything to add from
Yeah.
anybody? Any other thing other than this?
Yeah, and you can contribute yourself.
Yeah,
See,
true.
all of us. See,
We are
one
all
thing
practitioners.
which,
Yeah,
yeah,
we learn from others also.
all of us are in the same level.
Yeah,
Okay.
absolutely.
Sometimes
absolutely.
you might have more to contribute.
Experience than us
Okay.
also. Yeah.
You can share experiences.
The Zoom webinar is a learning platform rather than some so-called masters coming and presenting their studies. This is like we are sharing our knowledge. Dr. Felix and we all learn from your side also. So if you have anything to add, you can add that. And I really appreciate IHMA Kottayam chapter to coming up with such suggestions to
So
conduct
Dr. Danya,
PMS.
Dr. Danya has raised his hand.
Okay, Dr. Danya, you can turn on your audio and you can speak.
Unmute.
Or yeah, or you can send the message.
Might be she might have raised it earlier.
To stop. Maybe asking to stop us.
Okay, thank you, Dr. Danya.
It's already 10:40 there, no?
Okay.
No worries. So thank you all, and give me an opportunity to interact with the doctors in Kerala. Dr. Felix is my colleague in MD. Then IHMA Kottayam unit. See, I'm ready to share my platform because since it's there for to learn. Anybody, if you want any, just inform me. I am also happy to be part with that. And one more thing I want to inform you, like I have a YouTube channel, Dr. Simpson Joseph. The channel's name is my name itself. There I have uploaded few videos on what you call COVID-19, then one on hyperemesis, then one on how to learn mathematics in a different way, then some information on COVID, there it's economic impact and other thing. So you can subscribe that channel and you can watch that on also. And then it was a nice presentation from Dr. Felix side. It's a pure clinical experience what he is sharing. So we need such classes. We need to form such kind of platforms where we practitioners has to learn and relearn, because he explained everything. Like, see, we cannot say if NS1 is negative, that means it's with homeopathic medicine alone. So that kind of false claims we can what you call, we can stop such claims only if we learn the things in the proper manner. Very good presentation, Dr. Felix and Dr. Sajan. I really appreciate all IHMA members. Let's hope to continue such classes. Happy to see you all once again.
Okay, thank you. Once again, thanking you all. This was my first webinar. There might be many shortcomings. Please give me a feedback. I'll try to correct that. Also give a feedback regarding the presentation. Thanks to Dr. Sojan, Dr. Vishwamar of Kottayam IHMA, and special thanks to my colleague, Dr. Sinsan Joseph from Dubai. He's hosting this. He's giving us his valuable time. Thanks a lot, Dr. Sinsan. Okay.
Thank you all. Thank you all once again.
Thanks to all
Thank
the
you.
participants for your time and for your cooperation. Thanks to all. Okay, thank you.
So if you have any other topic to discuss, you can just share to us. Definitely, we will come with other topics. I think Dr. Anup will join with us maybe next week on COVID on kids, COVID-19 on infants and kids. We hope he will soon conduct one webinar. And the same platform you can use, like that username, password. I mean, password and ID of the meeting, everything is the same only. We want to make some good topics and good clinical discussions. Don't feel anything like this is an open platform where we can discuss anything on homeopathy. So I'm very happy, and once again I congratulate the whole IHMA team to come up with this idea and sharing our experiences to learn more on such topics. We can see Dr. Matthew Joseph also, senior IHMA members. Thank you all once again. So now we are concluding the meeting. Then if any other topics, just to discuss among us, and then we will host other meetings also. So we have to make best out of being locked down, and since the platform is there, it's perfect. Dr. Sajan, you want to add something?
Dr. Sojan?
Yeah, Dr. Sojan. It's a concluding note.
Conclude. Let us conclude.
Thank you very much. Conclude. Class
Okay.
Sinsan Joseph doctor coordinate. Thanks.
Okay, Dr. Sojan. If any topics just inform us. We classes we need such learning things, definitely. Introduction reluctant we are all practitioners, we are all students. Formality then only we will learn. I am senior practitioner. Nothing like that. I am a junior. If I ask the question, this is an open platform to discuss anything on homeopathy. Then only we can correct mistakes from our side. See, learning is always it's an never-ending process. So, this open to discuss on the platform to anybody can join. This is like an open platform for learning. Hello, Dr. Sojan, concept. Thank you. Topics Dr. Sojan, Dr. Felix, Dr. Matthew, contact definitely we will come up with some good clinically useful. Simply intellectual entertainment clinically topics we will discuss on that.
COVID class
Dr. Sojan, COVID video definitely I am ready to do that. COVID I am ready to do that. Not an issue. I am ready to do that. Not a problem. Classes video, but still I am ready.
Hello? Hello,
Dr.
Matthew Joseph. Dr. Matthew Joseph.
ഒരു ക്ലാസ് കോവിഡിനെ പറ്റി നല്ല ഇൻഫോർമേറ്റീവ് ആയിരുന്നു. അത് കാര്യം എന്താ വെച്ചാൽ നമുക്കൊരു കോൺഫിഡൻസ് കിട്ടും. ഈ നമ്മുടെ ഇവിടെ സിറ്റി ചാപ്റ്ററിൽ, കോഴിക്കോട് സിറ്റി ചാപ്റ്ററിൽ നമ്മളൊരു ക്ലാസ് വെച്ചിട്ടുണ്ട്. എൻ്റെ ഒരു ജസ്റ്റ് ഒരു കൊല്ലം സീനിയർ ആണ് രജനി. പുള്ളി ഇവിടെ ഇംഗ്ലണ്ടിലാണ് ഉള്ളത്. അപ്പൊ ഒരു 288 അവർ നോക്കി, അതിൻ്റെ ഒരു 40% പോസിറ്റീവ് ആയിരുന്നു. അപ്പൊ നമുക്കതിന്റെ നമുക്ക് മരുന്നുകളെല്ലാം സെയിം ഒക്കെ നമുക്ക് അറിയാവുന്നതാണല്ലോ. കിട്ടുന്ന കോൺഫിഡൻസ് ഭയങ്കരമാണ്.
തീർച്ചയായിട്ടും
വെക്കാൻ പറ്റുന്നത് നല്ലതായിരിക്കും. കേൾക്കുന്നുണ്ടോ?
കേൾക്കാം
Oh,
കേൾക്കാം
yeah.
ഞാൻ പറയുന്നത്
കേൾക്കാം
അപ്പൊ അതിന്റെ അകത്ത് ഒരു
ഞാൻ ഇടയ്ക്കുന്ന മാറുവാണേ, ചില എമർജൻസി ഉള്ളതുകൊണ്ട് ഞാനൊന്ന് പോവാണ്.
Okay. Thank you, Dr. Sojan.
Okay, then thank you all. അപ്പൊ നമുക്ക് ബാക്കി കൺസിഡർ ചെയ്യാം.
അവരുടെ ബോഡി ലാംഗ്വേജ് ഭയങ്കര കോൺഫിഡൻസ് ആണ് നമുക്ക് തരുന്നത്.
തീർച്ചയായും. അപ്പൊ നമുക്ക് വി ക്യാൻ പ്ലാൻ തിങ്സ് ലൈക്ക് ദാറ്റ്. ഇപ്പൊ ഞങ്ങൾ വി ആർ ഓൾസോ കൺസിഡർ ചെയ്യാവുന്നേ ഉള്ളൂ. ഓക്കെ, then thank you all. Good night.
Thank you. Good night.
Thank you. Good night.